Hello everyone, my name is Vanessa Barrientos, and today we are going to be talking about the role of pediatrics in applied behavior analysis. The following are the learning objectives the audience will master after viewing this presentation. These objectives include the benefits brought on by applied behavior analysis in pediatrics currently, the three subspecialties that can be greatly reduced if ABA increases its role in pediatrics. This includes reduction in problematic behavior, reduction in mental health crisis in children, and reduction in medication usage. They will also learn how these subspecialties relate to the 7 dimensions of ABA, how they can demonstrate mastery through 5 task objectives, and fulfilling 3 ethical codes through the associated work with pediatricians. Finally, they will receive suggestions on how to continue education and work with pediatricians. I start by presenting you with this quote made by Patrick C. Freeman. Skinner's vision of behavior analysis was that it would become a mainstream science relevant to all aspects of human behavior, and that it would be harnessed to improve the human condition substantively. Freeman understands that this was not the case in 2010, when he released his article, Come On In, The Water's Fine, Achieving Mainstream Relevance Through Integration with Primary Medical Care. Unfortunately, that vision has yet to materialize. This is not to say behavior analysis has not contributed to the merging. On the contrary, behavior analysis has flourished in specific areas of human concerns, such as merging behavior analysis with the philosophy of normalization. You see, throughout the 20th century, we have decreased the populations of most residential treatment facilities or institutions for people with severe developmental disabilities, allowing them a chance at normalized, satisfactory, and productive life. When used, behavior analytic treatments have in many cases eliminated and in most cases significantly reduced the disfiguring and sometimes life-threatening self-injurious behavior exhibited by people with developmental disabilities. Now, we've discussed a few of the benefits, but what this presentation will be discussing is the 3 decreases that will occur if applied behavior analysis is integrated with pediatric care. The 3 biggest reductions that will be seen are as follows. 1 will be reduction in problem behaviors. 2, reduction in mental health crisis in children. And 3, reduction in medication usage. Behavior analysts are already working with such a wide range of population. We see them in the business perspective as OBMs or working in the clinical setting, such as a mental health department, even working with animals in aquariums as animal behavior specialists, so this would only be an added population. It's also a population we are found regularly working with. However, it is so much more than that. Reaching this population specifically and working along side by side with pediatricians would mean that parents' concern would be addressed immediately, and a problem behavior would be resolved before it gets bigger. In fact, there's overwhelming evidence that suggests using intensive behavior analytic methods with very young children with ASD can normalize their development. Imagine this. You're with your pediatrician and ask, Little Johnny has been throwing really bad tantrums at the supermarket, and I don't know why. Well, your pediatrician might just say, It's just a terrible tooth. He'll grow out of it. Unfortunately, little Johnny doesn't grow out of it, and we find out that the function of the behavior was due to access to tangibles, Now little Johnny is 13 years old and still throwing tantrums when he doesn't get what he wants, because that's what he's been conditioned to do. Let's take a look at the following video. Yeah, not the prettiest sight, but it happens. And this is not what we want to see. Now, we are definitely not saying pediatricians aren't doing their job, but we have to remember that pediatricians are bombarded with clients on a daily, and report a 20-minute visit is not enough to cover or address an overwhelming amount of behavioral issues. This with the added problem is that pediatricians aren't trained to address these issues. ABA has already demonstrated the flexibility to adapt and generalize the critical components of the discipline to settings like schools, and the pediatric primary care setting is particularly ripe for replication of the success achieved by the positive behavior interventions and support initiative. Freeman actually talks about the common behavioral problems that are brought to a pediatrician's attention in his lecture, Behavior Analysis with Children and Adolescents, Behavioral Pediatrics. He states that some of these problems could easily be managed by behavior analysts before they get worse. Integrating behavioral health services into primary care, where most children receive their health care, can actually increase behavioral health services by 66% to 95%. This would mean more of us working alongside by side by pediatricians to help reduce these behaviors. ABA has already, in many ways, defined our ability to understand and manipulate unwanted behaviors of human behavior, to conduct functional assessment and analysis, and develop functional-based treatment recommendations that produce objective behavior changes. Currently, only 17% of pediatric primary care clinics have a behavioral health provider practice on site. So there's still room for growth. And hopefully, we can get to this before little Johnny gets to that. It's crazy, but believe it or not, there is an ongoing mental health crisis in the United States. Half of all pediatric primary care visits involve behavioral issues rather than medical problems. These including depression, bipolar disorder, and psychosis, which are the most common and expensive primary diagnosis for pediatric admissions. Predominate children's mental health issues that behavior analysts also deal with are ADHD, OCD, Tourette syndrome, and other clinical conditions categorized as anxiety and mood disorder. Half of the adolescents are believed to experience a mental or behavioral health problem, and rates of suicide are dramatically increasing. We are seeing higher rates of suicide in kids ages 15 through 24, and the sadder part is that 80% of the children who need mental health services do not receive them. One particular challenge physicians report is distinguishing between suicidal ideation, behavior, and non-suicidal self-injury. Being able to identify where the problem lies can help prevent the loss of another life. So, why can psychologists deal with this, you ask? Well, Megan McGrew speaks on the subject of how ABA is needed in the mental health department, saying that much of psychology deals with statistical analysis of how people behave and works to understand the underlying mental states that motivate behavior. Applied behavior analysis is rooted in B.F. Skinner's radical behaviorism. Although it did grow out of psychology, It is a field entirely devoted to behavior, and unlike psychological explanations, explanations of behavior in ABA are environmental and observable. Understanding behavior means understanding observable functional relations. We might be better at answering the following questions, such as why do people behave in particular ways? Of course, seeing this through a functional environmental explanation. What variables in the environment can be manipulated to alter human behavior? Why is a particular individual behaving in a particular way? How can we shape the behavior of a particular individual? Again, seeing all of this through a functional/environmental explanation. In 2009, Harvey et al. Writes in his Application of Applied Behavior Analysis to Mental Health Issues that ABA can be an integral part of multidisciplinary approach to mental health services in combination of techniques with other disciplines which would broaden or understand or help the understanding of mental health disorders. Much of the early research within ABA was conducted within state mental hospitals. Procedures such as token economies, reinforcement procedures, shaping, and extinction for persons with severe mental disorders such as schizophrenia were conducted by behavior analysts. He even goes above and beyond and explains how to reduce problem behavior in children with mental health problems and explains that ABA typically incorporates antecedent and consequence control procedures. Interventions may concentrate on triggers that set off the behavior, replacement behaviors, consequences that maintain problem behavior or maladaptive behaviors, or a combination thereof. I want to show you a list of the common medications prescribed by pediatricians for attention deficit hyperactivity disorder, also known as ADHD. For each medication, we have an age range for which can consume this type of medication. This age range goes as young as 3 years old. Mixed amphetamines is one of the medications that can actually be prescribed to 3-year-olds. Yet, one of the common side effects for this type of stimulant is addiction. Due to the shortage of child and adolescent psychiatrists and other specialized child mental health prescribers, primary care providers are often called on to prescribe psychiatric medications for children under their care. Mental health disorders commonly treated by pediatricians include ADHD, depression, and anxiety. In the United States, the prevalence rate of ADHD, as reported by parents, among children and adolescents 5 to 17 years of age has increased in the past decade from 6.9% in 1998 to 2000 to 9% in 2007 through 2009. Now, as behavior analysts, we commonly work with children with autism and other developmental disabilities, ADHD being one of the most common in our clients. Psychostimulants are the most globally effective medication treatment option for ADHD, and they are available in many formulations. As mentioned before, behavior analysts have had a big role in the mental health department, actually most of their start. Thanks to this, we have been able to help in the reduction of medication usage, such as in the studies produced by Drossel et al. In 2015. Drossel et al. Were able to help those with dementia before using medication. They found that adding psychotropic medications in the context of already compromised physical functioning and or complex medical regimens can have detrimental effect. Instead, Drossel recommends a serious effort of using behavioral interventions by first ruling out drug effects, undetected illnesses, or pain as the precipitators of acute and abrupt behavior, and, if indicated, treatment of delirium with first line non pharmacological interventions. Then, defining the target behavior that would be used for the intervention. The same could be applied to kids using medication. If through observation we notice that there are other factors that are increasing hyperactivity, could be sensory or food or etc., and those are addressed first, it could help lower dosage or even eliminate the use of medication. So, let's talk about how behavior analysts can practice the reductions and how we can put these practices through our 7 dimensions. We begin with the applied way. This can be done by demonstrating the social importance. Reaching problematic behaviors before they get worse prevents the client from reaching unwanted, impactful extremities. Meanwhile, in the mental health crisis, we can prevent SIB or possible death. And in reducing medication usage, we can prevent unwanted side effects that have been attributed to addiction or lead to even more prescriptions. We didn't specifically talk about measurement or topography, but this can help us apply interventions with measurable behavior. In the mental health crisis, we need to stay away from mentalistic thoughts and define, for example, sad behavior in measurable terms, such as eating under 500 calories a day or sleeping over 12 hours a day. We can also do this for the variety of different problematic behaviors that might arise, such as tantrums, which can vary from crying for 30 minutes to kicking the floor and engaging in SIB. Medication usage is a tougher one, but measurement of the behaviors that lead to medication usage could be accounted for. The analytic ways require an objective demonstration that the procedures cause the effect. Measurement for all the reductions will help in demonstrating these effects. Technological ways show the interventions are described well enough that they can be implemented by anyone with training and resources. If dealing with reducing the mental health crisis, let's find resources that can help with knowledge and implementation, such as a psychologist, and work together to come up with interventions that can be done at home without your help or by other professionals. Same goes for reducing medication usage. Find the attributing behaviors that lead to medication usage and apply interventions to lower them. This leads to the practice of conceptual systems, which say that interventions arise from specific and identifiable theoretical base. If you find the proper resources, then the intervention will come from a supportive theoretical base. Now, because we are reducing problem behaviors, mental health crisis, and medication usage, we're hoping that these will produce strong socially important effects. Reducing medication usage will reduce side effects produced by those medications. Some side effects that may have impacted the client significantly such as depression, addiction, and other medical problems. Reducing mental health crisis improves the client's social life and personal life, which can lead to decrease of other problematic behaviors associated with the mental health crisis. Finally, for generalization, we can use the learned information and apply it with other specialties, such as working in conjunction with occupational therapists or other medical professionals that you might find working in a hospital setting. These are the following task list objectives that I recommend mastery is shown if further interest in pediatrics arises. All of the chosen task list objectives fall under Section 2, Client-Centered Responsibilities. I do want to be very clear in saying that there are other task objectives to also consider and learn from, such as measurement. Measurement is very important because this is the way behavior analysts get their data. This is the way behavior analysts will base their decisions off. However, I do want to add these specific task list objectives because they are missed or underrepresented in our field, and I believe that they're actually very important. Let's start with G2, which is consider biological medical variables that may be affecting the client. As we've discussed before, parents bring their children for regular checkups when they are seeing their pediatricians, and that's usually where the question about the child's behavior arises. Because we will be working with medical professionals, it's important to consider those biological and medical variables, not only for the client's well being, but because we also want to take into consideration what the medical professionals that we are working along with have to say. It's almost as a form of respect and a way of building better rapport with them. Next is task list G3. Conduct a preliminary assessment of the client in order to identify the referral problem. We are in a different setting and environment. When we conduct our assessments, we also want the pediatrician's feedback and encouragement when speaking to the parent. This way, we can also try to implement the pediatrician's feedback into any possible future intervention. We are going to be talking to a lot of parents. Some of these parents might have background in ABA, but the majority most likely will not. This is where Task List G4 explain behavioral concepts using non-technical language comes in. We have to modify our language to fit this type of client. The client might already be very overwhelmed with all the medical terms they might be receiving from their pediatrician, and us adding on to that is not going to be very encouraging. And services in general could be very aversive to the parent. We also have to take into consideration the medical professionals we will be working with. One of my friends is actually a physician, and I forget that he has no knowledge of behavior analysis. I only realize it because when I am in mid conversation with him, I'll look at his face and it's very confused. Just because he's very knowledgeable in the medical field does not mean that he has knowledge on dealing with behavior like behavior analysts do. G6 is also very important because we will be collaborating with pediatricians and we have to build a good relationship and both support our services. This is the only way of building higher collaboration in the future. Finally, we arrive upon G7, which is practice within one's limits of professional competence and applied behavior analysis, and obtain consultation, supervision, and training, or make referrals as necessary. This specific task list objective should be followed thoroughly because we are not knowledgeable in medication consumption or in prescription. We have our boundaries and understand that there is stuff we can't always reach because it is out of our control. And we have to also understand that sometimes the pediatricians we are working with will have to take the lead. Moving on to our ethic codes, these are the three codes we will be fulfilling throughout our subspecialties. We spoke a little bit about this in our task list analysis, but I will speak on it again. Our services have to be defined within the context. We have to be professional and know our roles as well as maintain a scientific relationship. This includes modifying our behavioral language and keeping those professional relationships. Secondly, we will always have third party involvement because of the variety of different services that will be provided through a pediatrician. This code specifically will be the biggest to fill if you're working in a hospital setting because you will be dealing with a wide range of professionals. We have to make sure all parties are updated and informed of any changes, which means constant communication. We have to try to work around conflicting roles and make sure we stay within our own boundaries. Finally, again, this falls in the line with our task objectives because we are dealing with medical professionals, and as behavior analysts, we have to recommend seeking a medical consultation if there is any reasonable possibility that a referred behavior is influenced by a medical or biological variable. Lucky for us, if we're working side by side with a pediatrician, we can just say, hey, this is all you. Before we end this PowerPoint, let's talk about pursuing further education and training in pediatrics. Code 1.03 in our ethics code states that as behavior analysts, we need to maintain competence through professional development, through current scientific and professional information in the areas of practice, and undertake ongoing efforts to maintain competence in the skills used. This can be done by reading the appropriate literature. Let's read up on the medical diagnoses that are usually found in the clients we receive through pediatricians. Communicate with those we work with and ask for book suggestions. Let's attend conferences and conventions or participating workshops. If you Google conferences for pediatricians, you can get access to ones happening all over the world. Or ask the pediatrician what they're attending and see if you can attend with them or without them. Another